I'd like to welcome you to the Wheeler series on COVID-19. It's my great pleasure to welcome you, Tulsi. Thulasiraj Ravilla is the Executive Director of the Aravind Eye Care System. Aravind is the biggest eye care system in the world. To give you a sense of scale, Aravind is doing 2/3 of the eye care volume of the NHS. They're seeing 4.5 million outpatients a year. And also to give you a sense of who Aravind are, they are seeing 2/3 of the volume of the NHS at 1/100th of the cost. Also at extremely high quality. There are very few eye hospitals in the world that have been designated as a WHO collaborating center. What that means is that that hospital system can train other hospitals all over the world in their methods. Aravind is one of those hospitals. So it's going to be fantastic to talk to you, Tulsi. And also, you have a very diverse experience. You spent a significant amount of your early years in a big multinational, and only then did you switch to being with Aravind, which is a very different type of organization with a goal or a mission of eliminating needless blindness. I'm really excited to have this conversation with you, Tulsi. What I want to do, Aravind, is I want to use this time to get your insights on different ways that we can approach the COVID pandemic. One thing that is very well known about Aravind is that you guys have figured out ways to dramatically reduce cost while maintaining extremely high quality. And I want to ask you, given that you have such a long experience in doing that, what opportunities are you seeing in the current pandemic to use that type of thinking?
So I think in a situation like this, it's always helpful to get the priorities right. I would say the first priority for us and for, I would say, everyone probably on the planet is to do whatever they can to contain the spread and the growth of this infection. So in a context like this, one, you have this primary responsibility to the society as a whole. And then the second priority comes from a business continuity point of view as to what is critical. So in the context of developing countries, in the context of a service industry like a hospital, it is always human resource, because that really is the bottleneck for doing the business. So you really want to make sure you have a certain focus, which will address their concern this point of view, but also from realizing that because salaries in developing countries are not very high, and any stress on the salaries would also become a major issue for the staff. So becoming staff centric and then making sure their needs and interests are protected becomes the second concern. And then in a situation like ours, or a hospital like ours, wherein we are into eye care, where bulk of the treatment is elective, there are some emergency immediate cases that need to be done, but for vast majority it is elective. So elective, and then so getting organized to also take care of the patient.
Right.
Getting geared to do that while safeguarding staff safety and patient safety to reduce cross transmission. So that becomes a third priority. So these are the three macro challenges that we have had to deal with on an ongoing basis. And I would argue that this would be the very same for any businesses within developing countries.
Thank you. Yeah. And Tulsi, it's, the second priority that you mentioned about really protecting staff. And you talked about it in two ways. It's partly about things like PPE, personal protective equipment, so that staff are safer from the disease itself. But on the other hand, you also talked about protecting their incomes. And this is a challenge that every business is facing, and we are seeing a lot of layoffs in many businesses.
Yeah.
Your organization is also remarkable in that you have a tremendously large number of women employees. And you have used in your business model young women in remote villages who would never have had a job, have been a mainstay and are in fact involved in the operating theater in your Aravind hospitals. And that is part of the reason that you are able to offer that extremely low cost yet very high quality surgery, for example. So my two questions are, what guidance or thoughts do you have on how organizations can be creative in protecting their staff, and relatedly with women staff?
So in our specific instance, because of the design which you alluded to for staffing, we intentionally went about recruiting.
These are people who have a high school
education.
Women with a high school education.
Exactly.
Right.
Largely waiting to get married. That's the cohort. Yeah.
Right.
But don't have the means to go for higher education. And in rural areas, the employment opportunities also are not very high, other than occasional farming, which is seasonal. So since that became, that's a group that we wanted to both help and work with, by training them and employing them. So we also had to provide them safe housing. So a lot of these women, young women, stay with us on campus, and then in all our hospital, there's a standard design that we have accommodation which can house hundreds of these young women in the system. So during this crisis, that has really become handy in the sense because with the lockdown, one of the first things that got affected was transportation, both in terms of public transportation being stopped, and creating that huddle. So recognizing that our policy now is that people who can't travel are not expected to come to work. And so even though they are not coming to work, we took a policy that it is not out of their choice that they're not coming. So they would continue to get full salary for that period. And we also took the decision that we will not set it off against their vacation time or anything like that. So that's a decision we have taken from the management side. And also recognizing in a real level, so whatever fiscal strength Aravind may have now is essentially generated by this workforce. Both doctors, nurses, admin staff. I think it is a staff who are created financial strength as well. And for the group that's staying with us, one had to find other than beyond meeting the basic needs, of food and shelter, etc. Also to keep them engaged. So there are a number of activities which address to that, both by way of professional development and otherwise.
Thank you, Tulsi. Very interesting, because I think what I'm hearing you say is that Aravind has taken the decision that whatever retained earnings, etc., that you may have, this is a time to, in fact, use or dip into that in order to protect your employees, protecting their salaries, even going to the extent of developing employees in a crisis. And to me, this it ties in with how long-term a focus you take at Aravind. When I think of your mission, which is to eradicate needless blindness, it is a very absolute type of mission. It is not like most company mission statements, which say we want to be best in class, which means better than the competition. And when you're talking about eradicating needless blindness, you would know when you're done, right? There's a particular target, and I feel that that has helped Aravind in being very creative and deciding to completely reinvent procedures that have been around forever, like cataract surgery. I mean, who would think of completely changing how a cataract surgery is done and having the surgeon do only those parts which only the surgeon has the expertise to do, while other parts could be done with others who are differently skilled and who are not medical doctors. I just want to push a little bit that in a crisis where everything is about the moment, could long-term vision actually hurt? Taking a very long-term vision.
I think to the contrary. I think if you really have that clarity, I think, and to me, it is a long-term perspective which will give you a much better clarity on short-term decisions. And then you would recognize that they're not really in conflict. Like say you have this pot of money, and then you are wanting to buy an expensive equipment versus paying salaries to staff when no revenue is coming in. What would be long term? I think the decision will be pretty clear. Because if you lose the staff, it's going to take you, because you can't get staff by writing a check. You can buy a piece of equipment by writing a check. So, and then just to digress a little bit on the vision or purpose itself, when you quoted ours and a couple of examples, I also observed that say our vision tends to be more outcome focused. I mean, to me, I'm saying that best in class is a process goal. It is not really an outcome goal. And recognize that institutions which have an outcome purpose, tend to be a lot more purpose-driven in what they do. I think the actions and everything are much more easily translatable and connected to the purpose. So if it is best in class, you are almost bringing in certain boundaries, restricting your own potential to a great extent. So this has become, this I've noticed constantly.
That's very interesting. So in fact, you have broadened the challenge, and by taking such a huge challenge, you're right that it removes the boundaries. Again, thinking back to what you have said about we believe in our employees, and you can't pay a check to get an employee. At the same time, when you look at what so many organizations are doing where they are firing employees, one issue that comes up, I think, which seems like it is almost unstated assumption in the way Aravind operates, is that there is a confidence that if the world changes, you are somehow going to reinvent yourselves. And I have seen, and now working for 7 years on multiple projects with your organization, with 2 PhD students at London Business School, co-author Sarang Deo at Indian School of Business, Ryan Buell at Harvard Business School. What we have found is that Aravind is like the equivalent of a huge corporate. I mean, look at the volumes. You're doing 4.5 million outpatient visits in a year. That is a tremendous volume. And yet, when you see a new idea, I've seen tremendous quick baby steps towards innovation. And one example I saw was with this concept of shared medical appointments, which is an idea which in fact originated in the West. But when you came by that idea, the idea being that instead of having patients each seen one-on-one by a physician or a clinician, if they have similar issues, you could bring them in as a group, and each patient could then have their one-on-one with the doctor, but with others present. It's a dramatically different way of doing things. What I saw is you guys ran with that, but you didn't even first experiment using a clinician. You used a counselor and saw what this group session would be like. Then you tried it out on weekends. Then there were other baby steps before doing a higher level, like doing a randomized control trial. So the question I have for you is, what guidance do you have for businesses who may be, in fact, trying to cut costs and making these very short-term decisions because they don't have that confidence that they can actually find a way out of uh, experimentation?
Mm. Uh, I think in any businesses, I think there are both opportunities and they always come with constraints or limitations, by way of resources or regulations or whatever. It is to develop that capacity to stand back and look at it, and always in your own context of what you're doing. Like for example, in the example that you mentioned about shared appointments, we could relate to it immediately from a resource perspective, because we could quickly recognize that something like that can reduce the resource requirement, and at the same time actually not compromise outcome but enhance. So it wasn't very hard to jump at it, but then one had to go through a certain process to do it right. Because there is nothing called as a good idea. It's the idea that works that becomes a good idea. And we also had past experience of in that very specific example of doing group counseling, for especially for patients brought in groups from villages through outreach activities. So we would talk to them at different stages in groups, both out of necessity in terms of deployment of HR, and also recognizing that that was the best way for them to help each other as well. Because talking to say 10, 15 patients as a group, then you could stimulate a conversation amongst them before you wind up. And similarly, in this situation also of COVID, and where social distancing seems to be the most powerful way of containing the spread of the infection, we recognize it is going to significantly reduce our capacity in the current way of working. We recognize that in this mode of working, if we have to maintain social distance, then we'll have to turn away more than half the patients. So then we went back to the drawing board saying that we can't afford to do that, because that would very directly compromise the purpose of the organization, which is about eliminating blindness. You have certain resource, and if it can only produce half of what it could, then to that extent you're not fulfilling the mission. So then we did the work is actually ongoing. It will become operational from Monday. We did a whole capacity estimation, and then we realized, to our surprise, that the capacity limitation was around how many waiting chairs we had, not amongst how much staff we had. Now, social distancing required, you can't sit everyone next to each other, so you need to have a seat in between two seats. So that became the limiting factor, and then we determined the capacity based on that factor. And then another complexity was now with any patient contact, you now have to go through a sterile process. You saw a patient on a slit lamp or you examine them for glasses, so all those lenses have to be cleaned up again before you use it on the next patient. So this is exactly the same challenge you have in the operating room. No? So now we are following the operating room techniques in the outpatient. So we did a mock run a couple of days back to see how that will work, which really means we will have two refraction rooms for maybe 1.5 refractionists, or say for 3 rooms you may have 2 refractionists. So they would see a patient and then they would go to the next room where the equipment is sterile, and then in between an aide who is lesser trained person would come and clean up the equipment or the slit lamp or whatever. So applying the same techniques. So we are now coming up with a lot of process innovations to see how we can kind of move towards giving the same volume of care, under this new the rules of the games are changing now.
That's a great example that you shared, where um, I agree, you're thinking about the longer term, not just the lockdown, and also you have drawn from your own experience in a related area, which is something which I find often organizations don't manage to do. You could be doing some great innovative stuff in one pocket, but in another pocket, it is not necessary, or at another time for a different problem that those ideas would cross over. So that's great that you shared that. I wanted to share with you, Tulsi, one of my experiences. We are also in the education uh, business. It is very much a service, and in some ways similar to healthcare in the sense of the kind of it's a knowledge service. And I had my first experience teaching a Zoom class 3 weeks ago, where there were 40 students. It wasn't a very straightforward situation where I was going to be giving a lecture. It happened to be the last session of an innovation elective. So there were 10 teams of students who were going to present. There were 2 venture capitalists who had been invited to provide feedback. And all of this was done with everybody sitting in their homes all over the world. And when I finished doing that, I thought to myself that right now with COVID-19, as you said, there is a great need for social distancing. You can't come close to people, and care providers can't come close to patients. So I started thinking, and you also mentioned Aravind has tremendous experience in offering shared counseling. I started thinking that what the world really needs is a way to be able to offer shared care remotely. So, and also, we know that Aravind has one of the most well-established telemedicine provision systems in the world. You guys have been doing it since 2004, and from the study that we did, which is like an impact evaluation of your telemedicine program, where we were very careful to put in a proper control group, because sometimes you might introduce a telemedicine center, which is a remote outfit from which rural patients could meet a doctor who is in a hospital in a city. But if those places where you chose to put the telemedicine centers are special in some way, that could result in a biased view of what it's doing for the system. But even when we put in as controls other villages which are quite similar, we are finding that you've greatly increased access through telemedicine. So you have this deep well of knowledge in telehealth, and you also have experience in offering care to more than one patient, and more broadly, more than one client, right? If you think about businesses at once, do you see potential for combining these two together?
Yeah, absolutely, Yeah, I think we've been looking at this from a slightly broader concept. broader perspective, I would say. Like for instance, this whole task shifting, I'm just giving an analogy, when we use these high school girls who have been well trained to do specific tasks, which otherwise a doctor would need to do, or someone with a higher caliber would need to do. So we're kind of underutilizing those resources. So we took this strategic decision, maybe out of necessity, that a person like a doctor who has got this high level of skills would only do tasks that only they can do. Anything else, we would shift it to another person with appropriate training and quality control certification and so on. And that has worked beautifully for us. And then that's something which has really helped the system to provide both efficient, good quality, and then extremely low cost care to people. Now, if you extend the same analogy to saying that, can we identify all the tasks that we are doing in the hospital that need not be done in the hospital? Okay. I think we'll come up with a whole slate of things, and that's a conversation we just begun.
Right.
You know, partly encouraged by your planting the idea in our head, and that's the conversation we're having. So from registration to all the health education bit, today the payment also getting more complex. It is not like before, wherein you would just pay cash. It was like going to a hotel or a restaurant, you just pay for it. So it is so simple. But now we have this insurance. So dealing with the insurance again takes a lot of time. And today's default work is the patient comes to the system, they sit with the payment insurance people, and they spend several hours sorting that out. So none of that needs to be done in the hospital. Health education, counseling, registration, payment mechanism. So a lot of this stuff we should be able to build interface in the system, but have it done just as efficiently. And to the extent that we can transfer this onus onto the patient, I think it will be done even better. Like for instance, taking history also could happen remotely. And I think if you have some technology like a chatbot or something like that, that can interact with the patient, I think we would get much more consistent history taking than when we leave it to individuals, who, depending upon their mode and urgency and whatever priority they have, may tend to shortcut certain things. So certainly, yes, I think it is kind of opening up a lot of opportunities. And I think this scenario, which would have been very hypothetical if this lockdown didn't happen, we would never even apply or think in those terms at all. But now that we're in this reality now, so I think a lot of people are able to relate to this case scenario, to come up with a different way of working.
Tulsi, I want to ask you again, continuing on this idea of offering service to many at once and doing it remotely. Coming back to things that you have yourselves done for a very long time, the eye camps that you have been holding in remote rural areas as a way to find people who have problems with their eye, whether it is just needing eyeglasses or needing a cataract surgery. The way you have done it for, I think, 40 years now, is that in these remote areas, sometime before the camp, it would be as simple as one of those three-wheeler auto rickshaws. It could be with a loudspeaker attached to it, and an announcement being made along the village streets: Aravind Eye Hospital is coming. If you can't see well, please come to the eye camp in a particular location. And you have used that approach. I could imagine that today, in the situation that we are in, some kinds of care could be delivered in that way. We have a great need for care, a great need for counseling, and there are patients or even people who are not yet ill or have chronic diseases who are just anxious, and so and wanting to talk to others. There's also this physical isolation which is causing social isolation. You could imagine a situation where for certain types of care, there might be an auto rickshaw with a loudspeaker, and a doctor could be speaking and going through the streets of crowded streets of, let's say, a city underprivileged area, announcing that if you have certain types of symptoms, this is what you can do, or if you have other chronic diseases which are right now being ignored in this crisis and which are probably going to be a huge second crisis a few months down the road. So if you're a diabetic, or if you have previously had some heart related issues, these are some of the kinds of things that might be relevant for you even in relation to COVID. One could imagine this, but at the same time, something that I have learned to deeply appreciate from my interactions with folks at Aravind is that you have a very strong sense of respecting every individual and dignity for every individual. It doesn't matter who that staff person is, what their training is, and who the patient is, where they came from. Can that dignity be maintained while trying to do more at once by saying we'll do shared delivery?
I would think yes. I would also feel in sometimes this notion of privacy may be kind of overrated. I'll give one example, may or may not be appropriate. In the days when we had smallpox, which was rampant, one good thing was, or one difference was that with smallpox, people knew that you had smallpox, unlike COVID situation where it takes a long time and many testing to figure out that you got COVID. Smallpox was a lot more obvious. So any family across the country, across India, and I don't know about other countries, if someone had smallpox, which is now eradicated, they would place in front of the house, like in South India, it used to be a bunch of neem leaves.
The neem tree leaves.
Neem leaves. They
Right.
would tie a bunch of it in front of the house. And everybody knows that means that there is a person with smallpox in the house, and people should avoid that house or even the street. Okay, so this is about privacy. Someone is giving up the privacy for a society is good. So I think that to me seems to be a higher level of maturity than otherwise. Then I think if privacy is for one's good at the cost of public good, then I think one would need to question it. And of course, privacy has got different aspects to it. And in this healthcare context, I think there are certain instances where you got to respect privacy.
Great, thank you, Tulsi. And I think it's really interesting how you have highlighted that trade-off between what is the goal for the privacy, and if there's the own good or own family's good or own, there could be bigger clusters of that versus the broader good, gives a way to conceptualize and think about it deeply. I want to ask you, I had never had the opportunity to meet Dr. V, as you all fondly call him, Dr. Venkata Swami, who founded the Aravind Eye Hospital. And I know that one of the things that Dr. V said was that intelligence and capability are not enough. One must have the joy of doing something beautiful. Right? That was something that he believed in. But the question I have for you is, in the current situation in a pandemic where we have, so much mayhem, difficulties going on, how can one think of beauty?
I guess this is a time to think of beauty. When there is so much stress and misery going around. I think it gets a little philosophical, because I think all of us look for a source of energy. No, and I think the linear or the default thinking is it's external. No, like somebody gives you more salary, or somebody motivates you, done a great job, you are the manager of the month, or whatever it is. No, I think people kind of feel that's what really gives you energy. And then if the same person reflects, they will recognize that is not so. No, and because with those kind of external recognitions, a lot of other things also come along with it. You know, sometimes you lose friendship, sometimes you kind of invoke envy or jealousy, or which is not otherwise warranted. And then I think people who manage also somehow feel it is the external cues that motivates people. It might be true, but it's a very short-lived this thing. Like I had a very interesting conversation many years back with a head of an IT company. Now, and he was saying, "Oh, we have very low attrition rates. We have 2.5 to 3% attrition rate." I was really surprised. I said, "Gosh, that's phenomenal." Then it turned out they had like a 2.5, 3% attrition per month. No, and and that apparently was good by industry standards, which pays very high salary. No, so you recognize that those kind of cues really don't motivate people in the long run. So I think as it gets philosophical, because I think this whole thing of finding that motivation from inside you, which drives you to do what you want to do. I think that's what can really sustain. I mean, what I think we may call it as passion, we may call it as whatever. But I think that is what really propels people to some people into excellence, some people into glory. So they're not completely driven by outside. I mean, they may use the outside thing as a validators, but if they get motivated by it, then they're completely in a seesaw. So when they can't deal with criticism, they can't deal with, they feel they're being punished or whatever. So I think that's where Dr. B sort of came from. So that joy of doing, applying your skills, development, knowledge, what you have, translating into something that's meaningful for you, for whoever. That's the beauty that he was talking about.
Thank you, Tulsi. That's definitely leaving me and all of us with a lot to think about, right? Why are we doing what we're doing? It's a very fundamental question, and it's been fantastic talking to you, to hear your thoughts on many different issues. And I'd like to thank you on behalf of the Wheeler Institute for making the time for talking with us.
And likewise, Kamalini, I think this was a very stimulating conversation. Made me think a lot, and I really enjoyed it.
Thank you, Tulsi.
Thank you.